We have Dr. Corser from Bemidji, which is Sanford, myself, and then Dr. Perringer from, and depending on how you want to say his last name, Dr. Perringer from Duluth, Essentia. And we're going to be talking a little bit about some of the grant work that we've all been doing and a little bit how they are a little bit different. So it should be really fun.
We have some great upcoming talks coming up on Echo, so please check those out. And then there's other Echoes that you have the option of joining. Links are below if you need extra CME.
All right. Remember, we love to see people's faces, so don't be afraid to turn on your video. There is free CME, and that's only if you answer emails from Katie and answer the little 6 or 8 questions you got to answer. So do that.
And we love to see your faces if you are able to have camera on and interact. And we do not mind if you're eating lunch. I'm going to go grab mine here shortly.
Remember that if you have some questions, you can, now that you can see Dr. Corser and Dr. Perringer, you can probably call them. But we do take phone calls. If you have questions or problems, our phone numbers are on there. Always happy to help you if you have a patient that's kind of a problem and you need some help. So, all right. Now, oh, she wants to go back so you can get the phone numbers. I don't know. Can you go back to? Yeah, there's the emails and phone numbers. And then, Katie, are we going to have to start over the slide presentation?
That's fancy.
Oh, okay. I don't know. Did Ashley Anderson make it yet? Wow. So here's where we got going. Ashley had a few slides that she wanted me to chat about first, and then it will be Dr. Perringer and then Dr. Corser. And then I will finish up with some of the things we're doing at Centricare, just so that we can kind of give everybody a little bit of an idea of some of the projects that we are doing and the ways we're doing things in our EDs to basically improve this access to MOUD and rural emergency departments. And of course, Sanford is that whole northwest part of the state, Essentia on the northeast, and we're kind of in the central. So I'll go through quickly some of the slides that Ashley had wanted us to do. There's the objectives, which we don't need to waste a lot of time on. You can read those at your leisure. So some of the things that Ashley wanted us to talk about a little bit are some of the drug overdose facts about how this really continues to affect the lives of Minnesotans and substantially. Next slide, please. If we kind of look, I think one of the things none of us really think too much about, we always talk about overdoses of opioids, but psychostimulants, there's a significant number of them, and it's almost half of what all opioids are. So, when you look at psychostimulants as the major cause of overdose death, it's not like it's low. It's still pretty significant, and in some parts of the state, it's actually worse than it is where we are, especially down in the south part of this state. There seems to be more. Next slide. This is an interesting slide that just tells us, how poorly we're doing on treating patients who have MOUD, and these are actually patients that have had a previous diagnosis of OUD through any of the state programs for insurance, and currently don't get any medication for that. And as you can see, back in 2018, it's really between about 80 and 95% of people did not get any medications for their opioid use disorder. Now, in the last 5 years, that's certainly improved, and actually it improved more in the Native American group than it really did in anywhere else. If you look at the Black Minnesotans, there's still 84% of patients are not getting any medication for their opioid use disorder. So we have a lot of room to improve. And when I look at this, I often think, how many times do you see diabetics who aren't given medication for their diabetes when they've been in the hospital? It's probably pretty rare that they don't leave with meds. But yet in our world, people leave all the time, the emergency departments and the hospitals, without their meds for opioid use disorder. Next slide. So this is the whole focus of this is really doing MOUD in the emergency departments in our state. And this little grant that the three of us are involved in, and there's two other systems, which we'll talk about, are really working hard to change this. Next slide. And just as a standard of care, clearly buprenorphine and methadone are the standard of care for patients who have opioid use disorder. If you get buprenorphine after you've had a non-fatal opioid overdose, in fact, 62% reduction in the risk of opioid-involved overdose death. I tell students all the time that the minute we start patients on buprenorphine, we've decreased their all-cause mortality right away. And so it's really behooves us to get involved. And the problem is that only about 5% of people get buprenorphine in that subsequent year. Which again is just horribly low, and we really need to look at where can we get to these patients and get them on medications, and the ED, of course, is one of those places. Next slide. This is just a hospital-treated non-fatal overdose a little chart, and it's interesting that if you look at this pretty significant decrease. It's actually much better in the Twin Cities. They've had a higher decrease in the metro than we've seen outside that metro, but still, again, pretty high numbers. Next slide. This a non-fatal overdose is involving an opioid and showing how it's declined. Actually, when you look at what's happened with fentanyl and all these different other opioids combined, it's dropped roughly by around 30%, and so pretty significant. So when we look at the decrease in the non-fatal overdoses, heroin, of course, doesn't now make up much of a percentage of that. It's really pretty small. Frankly, I have maybe seen heroin just a couple times this year. It's just not been a big issue. So the main impact has been decreasing fentanyl overdoses. Next slide. This is just to help us realize that not all the reasons people go to the hospital are non-fatal overdoses. So it's just a very small proportion of the patients who present to the ED or to the hospital actually had a non-fatal opioid overdose. Often it's other problems. And I think if we listed those, it'd be things like infections, mental health issues, in withdrawal, patients who just are looking for help. And that is actually a much bigger proportion of the visits to our hospitals. Next slide. Just as regions, and we're going to be looking at the orange, and then on the arrowhead where Cole is, and Joe is up in that northwest area. So we're going to be looking at those three areas and what we're doing there. As you can see, the metro, as far as age-adjusted deaths per 1,000 people, is twice what it is in St. Cloud. So the metro still is unfortunately the winner, but not far behind is really that St. Louis County area and that whole area up in the Arrowhead. So, and just right behind them is the Bemidji area. So really we're looking at some pretty significantly impacted places. As you can see in the southern part of the state, we just don't have nearly the issue as far as overdose deaths. Next slide. This is just a thing that I actually wanted to just show that really the biggest gains we've made have really been in the last year. And if you look at some of the statewide trends, almost all the regions saw a pretty sharp decline in non-fatal opioid overdoses. And I think we all have to think about, why that would be. I do think that Narcan's been a huge part of that. I do think access to buprenorphine's been a huge part of that, especially rurally. But really this last year has been really a big impact year as far as bringing down those non-fatal opioid deaths. Overdoses, sorry, not deaths. Next slide. One last thing. This is actually a couple last things. We often think about jails as the place that people go, that as soon as they leave, that's the biggest risk for overdose. But this kind of data has been going on for quite a while. We know that when patients go to hospitals, especially the EDs, and they leave either AMA or they are discharged without medications, they are at super high risk for overdose. And it's actually twice as many of the overdoses happen when people leave the hospital as our jails. And so important to understand that we can do more. and we need to do that. So I think treatment as well. I mean, people don't think about that. One of my biggest beefs with treatment is that sometimes when people relapse in treatment, they just discharge them. And where do we get overdose deaths? We often get them from places like that. Next slide. And this just shows if you look at the tall blue line there, that's just really indicative of what occurs when somebody leaves the ED without medication, without being treated, that their highest risk is really, and 20% of the overdose deaths happen in that first day. So we have to understand that if we're sending somebody out who got Narcan or who's in withdrawal and doesn't get help, those first few days are very dangerous for them. So important to do that. California Bridge study, and most of us are pretty aware of what goes on there. They got a great website. They've indicated that 85% of patients who got MOUD across their emergency department study sites, of those, 49% were still engaged at 30 days. And I think that's a great benchmark. If you can fall in that area where you're capturing maybe half of the patients or even a third of the patients, I think that's really important. Next slide. And this is, I believe, my last slide for Ashley. This is just showing where the study is going on. These are the pilot sites where we're trying to do things with our EDs, both in our major EDs and some of our rural EDs, St. Cloud and Duluth and Bemidji, the three top ones. But we also, of course, have Hennepin Healthcare and Alliant Health are also working on a similar project. So those are our pilot sites. So next slide, I believe we're moving on. We're going to let Dr. Cole Pernger kind of talk a little bit about their project up in Duluth.
Thanks a lot, Kurt. So I'll talk about what we are doing as part of this project through Essentia Health, which is one of the big hospital systems up in Duluth and northern Minnesota in general. So next slide. These are the people that are part of our grant team. Next slide. So this is actually kind of referred to a few slides ago, but just want to show that the emergency department is really a critical site of access to medications for opiate use disorder. So this is kind of a landmark study that was published back in actually earlier this year. Emergency clinician buprenorphine initiation, subsequent prescriptions, and continuous prescriptions. And what they found, and there was ultimately a commentary or editorial based off of this, is that when looking at that California Bridge program that in California, that is about 80 to I think 85 to 90% of all the emergency departments in California have adopted these California Bridge protocols or a way of approaching MOUD with a real focus on navigation, like how to improve follow-up thereafter. And what they've found is that buprenorphine initiation prescriptions by ED clinicians increased by 0.1% to 5% of all initiation prescriptions in 2017 to 2022. So those years in which the California Bridge program was implemented. And just showing like the huge success of implementing MOUD in the emergency department, and which hasn't been a focus previously, at least in Minnesota. Next slide. So focusing on Essentia Health. So these are very brief overview. So we have kind of two main markets, the East market and the West market. East market, we have our mothership, which is here in Duluth. We also have Virginia, Moose Lake, Deer River, Aurora, Baxter Brainerd, which is probably our next biggest hospital system, and then Superior, Wisconsin. And then we have the West market, which consists of Fargo, Bismarck, Jamestown, Boston, and Detroit Lakes. And so when we talk about initiation of MOUD for this particular grant, we're initiating it in St. Mary's Medical Center, which is in Duluth. But the hope is that we can apply what we learn in Duluth to our other satellites in the East Market and West Market. Next slide. So provision of MOUD at Essentia Health, specifically in the emergency department. So we have an addiction medicine consult service that is based in Duluth, but also serves many or most of those satellite sites that we just talked about. And we can do in-person consults in Duluth and then virtual or telehealth consults in those outside sites. At this point, we have 3 physicians, 2 nurse practitioners, and our service, which actually just started a little over a year ago, is now up to 20 to 30 patients daily. So it's growing quickly, which is consistent with a huge proportion of hospitalized patients that are there with problems related to SUD. Um, Implementation of the California Bridge Protocol system-wide. So we're using the same protocol for initiation that they're using over in California, and we are also initiating that same protocol to keep things simple. And importantly, we are using a rapid high-dose buprenorphine initiation, which essentially we give higher doses of buprenorphine to flood those receptors, reach a therapeutic buprenorphine level very quickly, and very low incidence of precipitated withdrawal. Has a lot of benefits and kind of ideal for that situation in the emergency department where patients are in withdrawal. We are also, not to the same degree that they are in the Twin Cities, but initiating buprenorphine following naloxone reversal of opioid overdoses in the field. We are also doing that kind of in the emergency department and avoiding naloxone infusions by just starting someone on buprenorphine immediately following an overdose. And importantly, we're really trying to make easy or improve and make it easy to access follow-up care via improved navigation. Next slide. So this is the California Bridge Protocol. And so this is what we are implementing, in part because they keep these protocols updated pretty consistently throughout the year so that we don't have to do it. And this is basically what we want to employ. So I won't go into specifics here, not really the intended purpose of this, but we are implementing this again throughout the system, including at St. Mary's. And again, high dose buprenorphine initiation, where we give higher doses quickly to get to a therapeutic level. Next slide. So one of the unique aspects of Essentia Health is we have this huge or very large pool of SUD RN coordinators. And it consists of 4 nurses, 4 to 5 now, nurses that serve system-wide. And the hope is that we can expand this. And what these our nurses do, they are amazing. It's probably our most unique aspect of our care at Essentia Health is that these nurses can essentially function as a one-stop shop. So they schedule follow-ups with patients after they leave the ED, clinic, hospitalizations. They call to check in on patients. They're the one-stop shop. If people have any questions, they call that team. They have knowledge of the different satellite sites, specifically those areas, and have done a lot of training, mostly through practice, to basically help be our outreach. The big thing is it does need a phone, so there's a critical population that we miss by having our SUDRN coordinators not necessarily in person. These are all like virtually. And they can, again, do follow-ups. They can place referrals. They do brief assessment, check-ins, and importantly, like coordinate our care for us. I don't know how I do without them or what I do without them. Again, knowledge of the primary care providers who will and can manage opiate use disorder or substance use disorder in our particular areas. Or those providers that are comfortable or willing to provide buprenorphine for opiate use disorder or chronic pain. We also recently created a system-wide substance use and addiction care program to kind of connect all these silos at Essentia Health. It'll hopefully make funding a little bit more simple, and in the future, hopefully by connecting these dots, we can really improve the care. I won't go through details of that, not really the purpose of this, but I think that'll help the care or addiction care that Essentia can provide vastly. And we currently have kind of a robust inpatient addiction consult service that serves emergency departments and inpatients throughout the system. And we're in the process of starting a virtual telehealth bridge clinic or addiction medicine clinic, but specifically a bridge clinic, mostly because we have the infrastructure to do it and we can do it cheaply and start quickly. And we hope to start that in the fall of this year. And we could use that virtual bridge clinic as follow-up for the emergency department. And that's our hope and plan. Next slide. So as part of this grant, we want to work with community partners because the purpose is kind of navigation of care. So once we get follow-up in our system, like how do we refer them to integrate them into the recovery community and use our community partners? So we are using our CADT, or Community Alcohol and Drug Treatment Facility, which is located in Duluth. That is where Duluth's medically managed withdrawal takes place, or detox. They have an outpatient treatment program. That's where the Duluth Methadone Clinic is located, ClearPath. Importantly, because we don't have a lot of LADCs at Essentia Health, they're really flooded with patients, don't have a lot of additional capacity. Our community partner, CADT, is able to quickly and reliably provide comprehensive SUD assessments. They also can provide psychotherapy and give direction for sober housing, intensive outpatient, or just outpatient in general. So they can help be that, along with our SUDR and coordinators, to help guide treatment. And then Recovery Alliance Duluth is the other partner. And this consists primarily of peer recovery specialists and help, ideally, to kind of help patients integrate locally in the recovery community. And also are helping provide feedback to us from the community about what we can do better in the emergency department at Essentia Health. Next slide. So what about harm reduction strategies, or what strategies are we using in the emergency department at St. Mary's? So at this point, and again, we need to improve all aspects of the care we provide at Essentia Health in regards to addiction. But at this point, in the emergency department, we provide grant-funded naloxone take-home kits, hopefully eventually funded by Essentia. We don't yet provide safe injection supplies, hopefully someday, or hopefully in the near future. We can educate patients on safe injection practices. Importantly, we're trying to change and update our ED weapons and contraband protocols, which at this point, like many emergency departments, are very punitive and really there's a lot of stigma associated with a patient's first encounter with emergency departments, specifically ours, when they approach our ED, and it's really resulted in some negative experiences. So we're trying to really redo a lot of that, kind of using Canada as kind of an ideal model. And currently we don't provide test strips, wound kits. Hopefully this changes in the near future. Next slide. And then what are we doing for tools and training? Right now, it's a lot of education of providers, nurses, case managers, social workers, and repeated education. They're probably getting sick of hearing from us. We're trying to simplify ordering by creating some kind of streamlined order sets, withdrawal management, MOUD, alcohol withdrawal management. And then EIRH evaluators at Essentia will work with CDC, Minnesota Department of Health, and other evaluators to help us develop collection points to measure project progress and to provide data for 6-month reports. And I see that there's a couple questions. Does this dosing lend itself to precipitate withdrawal for ED patients? I presume you're referring to the high dose initiation, or otherwise termed macrodosing, and it's actually kind of, despite what may have initially been thought, a very low incidence of precipitated withdrawal. Not a huge literature base at this point, but from what is published and anecdotally, if someone is on that spectrum of opioid withdrawal, it's a very low incidence of precipitated withdrawal. Does Medicaid in Wisconsin cover MAT? I am not the best person to answer that, unfortunately. Do patients get scheduled for these visits, or are the patients able to schedule their own visits? They always leave the hospital or emergency department with a visit scheduled, but are also able to call those RN SUD coordinators to schedule visits of their own. And okay, and then I'll hand it over to Kurt.
Actually, it's Joe next. Dr. Corser
Okay.
is up next with Sanford.
Very good. Hey, thanks. I'm just, number one, I'm really grateful to the OD2A people for bringing us into this project. It's been of great benefit learning from both Kurt and Cole. Cole just did a great job of reviewing the whole OD2A process. We can go to the next slide. These are some of the people working with us here. Melinda Broden is a SUD, LADC, and a counselor, and she has been a big help in our program. Megan Hansen is a director. Nikki Clark is our patient navigator with lived experience, and that's something that's really helpful in the emergency room, is have somebody with lived experience to help these people feel better about the environment that they're in. And then Sarah is the one who helped put all these slides together, and she kind of keeps the whole group together and in the meetings. We can go to the next slide. And so these are the same areas around the state. They're EMS regions, and we're, of course, in the Northwest. And just a couple of things from the Minnesota Department of Health. Overall in Minnesota, there's many more males than females that are involved in non-fatal opioid overdoses. But in our region, in the Northwest, it's distinctly different in that there's an equal number of females and males with non-fatal opioid overdoses. And if we go to the next slide, you can see that overall in the state of Minnesota through 2016 to 23, the incidence of neonatal opioid withdrawal syndrome was very similar throughout those years. But in difference, the Northwest region was by far and away the most common place for kids to have neonatal opioid withdrawal. And so we were an outlier in that department. And so we can go to the next slide. And so that happened in Bemidji, where we had many babies born with neonatal opioid withdrawal. And so we started pediatricians in Bemidji, did a lot to get the whole protocols for sleep, eat, and console going in the state of Minnesota. And we started with educating OB patients, OB providers, and the nurses on OB. And we were doing that work probably starting in 2016 or so. And did a lot of education with providers, with pharmacy, nursing, and care managers in the hospital certainly have been our best resources, because they suggest people to participate in or identify people and help the hospitalists and other people, pharmacy, understand that those people need to be started on buprenorphine. We participated in the exit entree study, which was originally from Oregon, and Hennepin County was the local Minnesota person who administrated that grant and study. And it just involved patients who were admitted to the hospital, started on buprenorphine, and 60 days after discharge were they still on buprenorphine. And so that led to a whole bunch of baseline work. We can go to the next slide. And so when OD2 came, OD2A grant came, we really expanded our work in the emergency department and broadened our scope. We have this one page, or all the providers in the ER just wanted one page to be able to give them some information about how to do MOUD. And it's very similar to the California bridge protocols that Cole was talking about. We also were able to start an EMS program where the ambulance in Bemidji was starting people on buprenorphine right after an overdose, and that's been very effective. We have been working with the county jails, both in Mahnomen, Hubbard, and Mahnomen counties. So Hubbard, Mahnomen, and Beltrami counties. The jails refer patients to the ER for inductions, and we've been able to talk with the jails about oftentimes the patient's dose would be decreased to 8 milligrams because that was a study that they had heard before. And so now we've got the jails using a more standard dose with the dose that the patient's on as an outpatient and is continued, and we get them started in. So that's been very helpful. The behavioral health department in Bemidji has been involved in the jail doing assessments, but now they have a number of LADCs that actually do therapy in the jail with people who are on MOUD. And so that's working out really well. And then we've developed relationships with nurse practitioners that do the medical prescribing and healthcare in the jail. And so I think that's been a very worthwhile project and been pretty successful. We can go to the next slide. In our ER, we have the same ED navigator that Cole was speaking about that does a lot of work with finding patients, getting them connected to outpatient resources, and that sort of thing. We've started with starter packs in the ER. So we have a package of 6 days worth of 8 milligram Suboxone strips that total a dose that would be up to 24 milligrams for 6 days. And we think that that's enough time to be able to get them into the recovery medicine clinic as an outpatient. And so those are in the ED. We have these locking back bags, and we have a foundation grant from Sanford Foundation for a bunch of naloxone. So we send patients home with a naloxone, fentanyl strips, xylazine test strips, and a voucher for a gas card. One of our biggest barriers is transportation in the Bemidji area because it's just such a wide geographic area. And so people get that voucher, they take it to the recovery medicine clinic for their first appointment, and then that gives them the gas card to be able to purchase a gas with when they come to their appointment, a bunch of education materials and contact info. And then our navigator gets them an appointment in the recovery medicine clinic. And so people get appointments when they leave the ER, but we also have the patient's ability to hopefully walk in. We hired enough people in the recovery medicine clinic, so we're able to accept walk-in. People can just come in and say, I need some help. And so that's helpful. And I think that one of our biggest challenges is the locum ER provider. All of our full-time providers in the ER, I think, are up and running and using buprenorphine well and feel comfortable with it. All of the OB providers do, but both in hospital medicine and some of the ER providers, our locums aren't accustomed to doing this. And so we try and educate and re-educate and re-educate, but that's been a difficult population for us to reach. The other thing that we've been able to do is reach out to other communities. And so we're working in Bagley and have gotten that emergency room up and running. They have buprenorphine take-home packs and education. In Mahnomen, we are working in the emergency room there and have a new champion in the clinic in Mahnomen, and that's working out very well. They started a recovery medicine clinic there. Cass Lake, we've done a number of presentations there, and the pharmacy over in Cass Lake is doing an outstanding job with providing harm reduction kits. And they've had a number of successes with people who come to the emergency room and doing that sort of thing. We've also, Mindy especially, has done a lot of work getting the program in Fargo, North Dakota, up and running with a recovery medicine clinic and buprenorphine in the emergency room there. And so we're trying to bridge out. We haven't been as organized as Cole sounds like he's doing. That's great work. And we hope to do that sort of thing. I think that we're working with local county jails, and I hope to increase that work. We can go to the next slide. And then I think over time, we started this back in 2016, and doses, the way you go about starting a patient on buprenorphine has changed so much, and it continues to change now with the advent of injectables. A lot of people are doing a lot of good work with those, and I think we need to implement them in a bunch of different areas. So it really is something where you have to, it's hard to create a protocol because 3 months later, the protocol kind of outdates and you need to update it and move forward with the new data. So we can go to the next slide. So this is just a case study of that macro dosing that Cole was speaking about. This is a 28-year-old female I saw who was about 16 weeks pregnant, fentanyl and methamphetamine use disorder. She was arrested, brought to jail in Bemidji, and began to have withdrawal, and so was brought up to the emergency room. In the ER, she had a pulse of 80. She felt somewhat comfortable, mildly anxious and achy, but no diarrhea, pile erection, restlessness, or other real objective signs of withdrawal. And she thought she had been up all night the night before and was yawning a bit, but had just thought she was tired. She felt her withdrawal right now at that time was mild. And so we put her in an OBS bed in the emergency room, and we can go to the next slide. 6 hours later, her COW score had risen to 10. She had some pile erection and a pulse went up to 106, and so we gave her 16 milligrams of buprenorphine. She felt much better 30 minutes later. She felt she needed more medicine, still had some withdrawal symptoms, gave her another 16, and she did fantastic, felt much better, slept in the first thing in the morning, was taken back to jail, and was continued on 24 milligrams of buprenorphine daily there. And then from the jail, then she was discharged to an inpatient treatment program. And so she did really well with this macro dosing protocol. And 5 years ago, I never would have done that. So that's just really works well. And then I think it would be good. Let's go back to the last slide and ask, what would you guys have done with this patient, 28-year-old pregnant patient with mild withdrawal who presents to the emergency department? Would you guys have started her earlier than I did?
I generally would not have. I mean, if I was going to do something, and I'm going to talk about that in my part too, that we occasionally will do a very low dose overnight and then macro them. But I probably would have waited, if I had the ability to macro her when she was ready, because it's just simpler. And if you do something like I do sometimes, where I'll do low dose overnight, a jail's not going to do that. Okay. And so I think that was perfect.
Yeah, very good. And so that's all I
agree.
had.
Cool. Go ahead.
I just going to say I really agree. I think this is a tough case. I'm not sure exactly the right thing to do, but I would do what you did.
Very good. So that's where we are at Sanford, working hard. Really appreciate the OD 2A project and the people who've given us those resources and spurred us on to work more regionally. So that's working.
All right, so I'll finish up. Next slide. This is actually our centric care team. We got quite a few nurses. We have some wonderful nurse practitioners. We've got lots of people in the ED and pharmacy staff who've been involved in our program. And so it's just been a ton of work, as some of you know, when you're starting to change protocols, add protocols, change what medicines you want in the ED. It takes months and months with Epic and building all this. So it took us quite a while. Next slide. And all these people were so helpful. So this is actually a recent case, and this is just to talk a little bit about one of the other ways that we're doing things in our ED. We had a 30-year-old female who actually had been a previous patient of ours, and she showed up with an accidental overdose, and she actually got 2 doses of Narcan on the scene. And actually, when I just stopped over to the ED to take a peek at her, was still pretty drowsy, and I had them give her I gave her another Narcan while she was there, and actually was able to then converse with her. Next slide. She was also using a little bit of methamphetamine, but we really had no that wasn't really quantified. We knew she'd been using both of those together. She got that repeated Narcan. And actually, I had a nice conversation with this young lady, and she got a little more alert. She was a little tachycardic. Her pupils got a little big. And so, to be honest, next slide, we decided we would give her the test dose of the buprenorphine, which is part of the protocol sometimes when we're going to give Brixadi injectable. She took that and was fine after 10 or 15 minutes. And I had the nurse give her a shot of Brixadi, 24 milligram injectable. I actually hung around the ED for about 15 minutes to make sure she was fine, left. And ironically, she got tired again and went back to sleep. That's a whole nother talk we can give at some other point. Next slide. But they felt at that time when they called me, they decided to start an Narcan drip on her, which, to be honest with you, didn't make a lot of difference. This was a very confusing patient from that standpoint, but the points that we're going to be making are a little bit different. Again, we could have a whole nother talk about why she was so sleepy and tired. So she just got supportive care. The Narcan was discontinued. She was doing well. Next slide. And was actually discharged home on the 15th. So 3 days later, was not given a prescription because she had an appointment made at our clinic. She had Brixadi injectable in and would cover her for 7 days. So we really didn't need to do anything. But then the next day we were contacted by our county jail. Next slide. And this was a bit of a fly in the ointment, if you will. We had everything set up perfectly. And we weren't really sure how long she was going to be in there. And so the jail called and wanted to know about the Brixadi because that's not something they'd seen. And I said, listen, why don't we just start her on 8 milligrams twice a day and let's just get her on that until she comes back. Next slide, so that we get her back to the clinic, making sure that she still has plenty to bridge her. Unfortunately, the correctional nurse said that they don't do twice a day dosing, that they give her 8 milligrams once a day. And so I said, well, why don't we do this? Why don't we give her 1.5? Why don't we give her 16 milligrams just once a day? And unfortunately, their standard is 8 milligrams a day. It doesn't matter what they're on. So we certainly clearly have a little issue with that. I loved the fact that Joe just talked about how they were giving somebody 24 in the jail. That's the right way to do it. And so we're always working on how we can improve the care, and that's one of the ways. Next slide. So, the patient actually came back to the clinic. Now, interestingly, before she came back to the clinic and the Brixadi was still on board, she used fentanyl 24 hours prior, had no effect to it. So again, we protected this patient with the Brixadi. She came to the clinic the next day, got the buprenorphine, got a prescription, and got prior auth for Sublocade, which she got on April 1st. So all these little things that we do sometimes, and again, I love the idea of Brixadi in the ED when it's, when you have that availability, because, she left and she used. And we kept her out of trouble. We kept her safe. She didn't have that overdose that we see from leaving the jail or leaving an ED. So it really, although it was not the perfect ride, it was a little bumpy. In the end, we really did well. Next slide. Capturing this patient. She actually came back after her first Sublocade. The nurse wrote in there she looked brighter and more hopeful that things were going well. Got her second Sublocade. Went to treatment and scheduled for follow-up, and is currently seeing one of our nurse practitioners. So I do think that there's an advantage for systems to consider the Brixadi as well. It's something that you'll see in a moment. It's one part of some of the things they do with both in our hospital. They've done in Hennepin. They've done at California Bridge and other places. So I do think there are advantages. Next slide. So what are the things that make me hopeful? Well, she got this and she used, and we still won, right? She got some bupe in the county jail, not a therapeutic dose, but she got some, and that's progress. In this state, getting any buprenorphine in the jail is progress right now. Next slide. I think that, she got transitioned and it worked. Our prior authorizations are getting easier and better for Sublocade. So if you're not currently doing it, I do think that it's getting better. She went through treatment. And I do think that one of the things that really brings our whole, kind of the whole circle together is we make a real effort to talk to the ED and let them know how patients are doing. We've had some really wonderful cases where our ED doctors have really went out of their way to make sure patients get the right things since we've started our program. And we always want to make sure they know the patients that they were involved with did well. And I think that's perfect. Next slide. I do think that, how our program operates was a bit adapted from what we call our Towns program, which we developed in Morrison County years ago with the nurse navigator. And actually early on, my nurse that was working there, that's on our team now, Brittany and I sat down, and she'd worked with the Towns program previously. So we kind of knew how we wanted to use a navigator. Because navigators really drive these programs. The doctors, if you look at what I do, I'm not doing much, right? I'm just the fluff here. We got the nurses who are really doing the job and making it happen. And they're making sure that the ED care is what it should be. And our nurse navigator now is actually in the ED all day long when these patients come in. So we have her to help with transition to care, making sure that these patients are connected, and that the ED has a really good idea of how we want to work our program. Next slide. And so they're really working over there, and I think their ability to navigate as well the protocols that we have. We've done all kinds of things with the pharmacy to make it move quickly. The navigator goes in there and actually assesses the patient with the nurse from the ED. And so much of this is about modeling in my world. It's our nurse. How does she talk to this patient? How does she get the information that she needs from that patient? And so it's really this emphasis on the accurate assessment and the history in these patients that really guides us as to what we're going to do for their care. So it's all about modeling. And I think our nurse navigators, this is really critical. Next slide. And so all these order sets that we have, I think it's great that they're set up. Everything is in there, but our navigator is really there to help teach them how to use them, so that when they're not there, and when this grant is over a few years from now, that they can all navigate these really well. We as well send the Narcan sets home with people, and we try to make the processes as simple as possible. And there's been some areas that have been refined. As Mandy, who does much of the navigation now, is in the ED, we found things that worked. We found things that didn't work. And so we try to be nimble and kind of change things as we can. Next slide. And again, this education part is so huge for providers and nurses. We've actually had in-person lectures with our nursing staff by myself and by Mandy. I think Mandy and Brittany are working on nurse education now to just continue that, because again, they drive the ED. They're the people that make things happen in the ED, and it's important that they kind of follow a certain way that we're doing these things. We actually started making videos, and I do these videos that then we send links to the staff on educational things, on situations that might arise. And the last thing that I do with some frequency is I do walkthroughs. I'll go over to the ED, walk through, meet all the providers, and make sure they have my phone number in their phone, and they can call, and we can make sure that if they need help in the off hours, that they can get that. Next slide. So this is historically what happened in our ED. You'd have an overdose, you'd get Narcan, they'd give you a couple of medicines to make you feel better, and you'd get discharged and told to follow up with your primary. This is literally a year and a half ago, right? And if you had opioid use disorder with or without withdrawal, you got a phone number to the clinic, a clinic that did buprenorphine. You had to call and make your own appointment. It might be days, it might be weeks until you've been seen. I can tell you this doesn't work, and we all know it doesn't work. Next slide. And really the way we've tried to change that is we're trying to do this OD just like, again, what Cole said and what Joe's saying and what they're doing out in California. We want to make sure that they get treated quickly if they have an OD. We want to make sure that if they're in withdrawal or they're not in withdrawal, that we have ways of starting them. And we actually do two different things. So we also do the macrodosing if they're in a situation with their withdrawal where they have a high enough COW score, and everything fits together. We macrodose both in the hospital and in our clinic, but we also use a modified macro low dose that we call LOMA if we get patients who sometimes show up to the ED in absolutely no withdrawal, right? They just want help. And I'll explain what that is. Next slide. So again, we do the same protocols in the ED and in our clinic. We like to teach that it's very important that there's so many variables to determine when you start or how you start Suboxone, and we'll talk about that in a moment. And there's a lot of really effective ways to do buprenorphine inductions. You just need to learn how to do what's comfortable for you and kind of evolve as your comfort level increases. There's just a few things to avoid, right? It's that, man, make sure that if you're going to start buprenorphine, especially if you're going to do macro, that they really have the cow score that's going to make things go okay. In my experience, when we go to the middle doses where you're going 6 or 8 milligrams in people, sometimes that's the phone calls I get with precipitate withdrawal from small communities. Next slide. So, these are the questions that we're always thinking about, and I think it's just so critical that people ask about last use and how often. I think about polysubstance use because it affects my cow score. It affects people's pupils. It affects a lot of stuff. What else is in their serum? And so, I often quantify what they've taken by how much they're spending. But there are a few things that always make me comfortable. That's that high pulse. They're sweating. They're getting up and they got diarrhea in the bathroom. Those are the things that we really want. I love to know if somebody's precipitated again, because that's a person that's going to be more anxious. And often if I get that, I'm not afraid to use a little benzodiazepine in the ED to kind of help them also not get so much anxiety that we're get confused as to what's going on. Next slide. Couple more slides left. So the simple version, I think, before I kind of talk about this, just the simplest part of our protocol, I just want to say that every speaker who does a presentation on BUP has a little different take. And I think that, remember, protocols are guidelines, and you'll modify them in different situations. You've got to use your clinical judgment, always use a little bit of caution. But there's variables that are out of our control, and sometimes it's what's in the drug supply. So just understand that there's just a lot of information you always want to have when you're taking care of a patient. It's not a one size fits all. Next slide. So this is really what we do in just the simplest terms. And this was exactly what Joe did. We will use a macro dosing in somebody in the clinic or in the ED if their cow score is appropriate. And it's been a longer time since they've used. We will go right to the 16. I've gone as high as 48 or 64 in the ED. I'm not afraid to go high. More can be better. This is exactly what Joe's case was about. Works wonderfully. Next slide. What if they're not in withdrawal? And here's what we do. We get patients sometimes walk in at 4:00 and they aren't in withdrawal at all. They used it just about 2 hours ago. Or we get a call from the ED and they just used and then showed up and want help. If they're in the ED, we can give them a lift and bring them to our clinic and have this conversation. If they come to our clinic, I do what, again, we call the LOMA, where I will sometimes give them a milligram every 2 or 3 hours. I'll have them cut a 2 milligram strip in half. And every 2 to 4 hours overnight, when their symptoms come back, I'll have them just take a tiny dose to keep them from feeling horribly sick. And then when we bring them back in the morning in the AM in our clinic, I macrodose them. I give them 16 to 24 milligrams. It works great. We've had many patients do real well. I'll have to say it always works the best if there's somebody with them who's staying with them and they're up and they're taking them when they're sick. I've had a few people not follow the instructions, and that can always be a complication. Next slide. So again, it's just this combination, and I just talked about this. Again, when they come back that next morning, I almost always, frankly, go to 24 at the minimum nowadays, but sometimes 32. Next slide. That is also a part of our protocol at the hospital, although generally they'll call us about that. Now, the post-OD thing, again, this was the case basically that I had at the start. One of the other options other than Brixadi is to actually give them oral right afterwards. If their COWS is up, you can give them that 16 milligram sublingual dose, and then a prescription for up to 32 milligrams a day on discharge. That works really well. You'd love to get that medication in, the sublingual Suboxone in within 30 minutes. When they're actually in withdrawal, you want to do it relatively quickly. That's sometimes been an issue for us because sometimes patients don't get to the ED real early, and that does seem to make things a little more complicated. We do follow-ups almost on everybody the next day. We squeeze people in. We want to make sure that they get seen, and we make sure they have transportation. Next slide. What are the challenges? And these are the challenges everybody sees. When we talk to the California Bridge people, when Cole and Joe were out there and we talked to them, they're only 8 to 5. They have their navigator in the ED 8 to 5. in a perfect world, our navigator would be there 24/7. Currently, those night and weekend questions also often come to me. I don't mind that. It's not as often as you might think, but we need to kind of get the ED kind of rolling a particular direction. One of the challenges is how many staff we have to educate. It's a lot of staff. And so, we've got to motivate them to use those order sets, and some staff are a little better than others. And as Cole mentioned earlier, stigma in the ED stigma, still something that we're working on, and I think we'll continue to. So next slide. Right now, this is the last slide. I believe our program has had 67 encounters for patients who were given MOUD in the emergency department. 37% of those patients have been retained. Again, not the 49% that we saw with California, but we're moving that way. About half of these patients have had contact with our navigator during the day. The other half were actually our ED providers doing it either by calling me or just working the system themselves. And so we're pretty happy with that. It's a lot of patients that we've captured that were never captured before. Next slide. And that is it. And I do think we have a little time for questions if people have questions about specific ways that people are doing things.
I think Cole got all of the ones in the chat from earlier, and I don't see any new ones popping up yet.
Any final comments or thoughts from Joe or Cole about different things that might have come up while other people were talking?
Does anyone have a good way of finding active list of SUBLOCADE providers for ongoing care? I'm in Grand Rapids, obviously, pretty rural, and it's hard to find. The last time I looked for a list, I'm like, that can't be right.
So SAMHSA used to have one, and that is no longer available online. And I believe Jessica Hultgren at DHS is working on a comprehensive list of Minnesota prescribers of MOUD. So more to come on that. But as far as I know, there's nothing that's rock solid at this point. The SAMHSA one was really outdated the last time I took a look at it. So
that's probably the one that I'd seen.
Who did you say was working on that list?
Jessica Hultgren. And I don't know that for certain, but I know that was on her wish list of things to be able to help everyone's day go more smoothly. Because I think we all ask the same question. If we get a patient in a bind somewhere, okay, who's in close vicinity? And how do we give that warm handoff? So it's definitely flawed, but I think there's work being done on a comprehensive list.
Cole, you had a thought, it looked like.
Oh, I mean, we have some individuals at Essentia that can give you information on Essentia sites that kind of have their tentacles everywhere in northern Minnesota. But yeah, I think Jessica's list that she's putting together is going to be a lot more useful for everyone.
Yeah.
And I do think it would be nice if SUBLOCADE was a little easier to get in a clinic through the REMS program. I'm actually a hospital-based clinic, and that made it much easier. We've had many calls from some of our outlying satellites, and it's like for them to get it is quite difficult sometimes. And I think that should be fixed.
Kurt, Jamie asks in the chat for 3 providers that presented, how do you get around prior auth in the ED? Some have utilized grant funding in this situation. Is that what you also use?
No, you cannot use grant funding for medication. I'm going to love saying this because I don't really believe it. I didn't believe it before, but it's happening. Centricare is eating that cost if they get Brixadi, if it's not paid for. And so they did put a limit on 1 per year per patient. But if a patient comes in, we're giving it and we're not even trying to get it. We're sending it in later. We have not heard whether they're getting paid for. We've done a few of them. But Centricare was kind enough to just say, no big deal.
I talked with a physician down at the University of Minnesota who was using the opioid pharmaceutical company money that the county got to be able to provide injectables in the emergency department. And so that's something I'm going to explore here. And maybe that's an avenue everybody could use.
That
Joe,
is
we've tried that. That was something I was hoping as well.
one of our upcoming presentations is on opioid settlement funds and the dashboard. And we say this over and over again. If you don't know where your county's funds are being allocated, it's very helpful to know so you can get at that table for things just like this, medication costs or using it for meds or staff in the jail, things of that nature. So a lot of times we've found, it's being spent on things like child protection or like education, and those things are helpful too. But there's certainly some areas where we could all benefit from leveraging those funds.
Yeah. My final comment for everybody would be this is that, and it'd be interesting to see what Joe and Cole think, but honest to goodness, to get this started in the ED with the protocols, with the medications, with all the hoops we had to go through, it really takes time. And so start now, because it's going to take you 6 to 12 months. So start now. I wanted to do it the next day. I was like, okay, we have the grant. Let's start doing this. And that did not happen. I don't know. Maybe it happens at Sanford and Essentia, but it didn't happen here.
That's
No,
my experience, Kurt.
Yep, I agree.
I think Cole froze.
No, I completely agree.
Okay. All right. Any other questions before we let everybody go on with their day? All right. Well, thanks everybody for coming. Thanks, Joe and Cole. That was nice to do this as a practice round. We'll be doing this at the rural clinic, what's it called? Who remember?
Rural Health Association, right?
Yeah, it's the rural conference in Duluth. Yeah, rural health conference up in Duluth. So thanks so much for everybody letting us kind of give it a trial run. So
have a good day.
Thanks, Kurt.
all right, see you guys.